and this is my presentation on a critical case study of pediatric diphtheria. Introduction-wise, we have a patient named John Doe, who's a 9-year-old boy that presents with mild fever, cough, and sore throat for 5 days. He goes to a local clinic and is diagnosed with pharyngitis, where they give him an unknown oral antibiotic and pain reliever. On the third day, his fever actually decreased and had no sore throat, but did develop neck swelling, difficulty breathing, difficulty swallowing, and made abnormal breathing noises, which led him to go to a hospital, local hospital, where they did initial evaluation. They checked for his blood pressure, his heart rate. They checked to see if he had a fever, what his respiration rate was, and oxygen saturation levels, which showed elevated heart rate, elevated respiration rate, low oxygen saturation levels, inflamed tonsils with white patches, neck swelling, and deficient air entry. They ended up going to refer to this patient to Chiang Mai University Hospital because they can sense that it's some sort of infection and that it's a bit more complicated than what they're dealing with. Which at CMUH, they ended up getting a health history. I know there's a lot of information on this slide, but the most important thing to get out of it is that the patient had an incomplete vaccination history. He had no previous health issues and also was in no close contact with other sick people. Initial evaluation, he had no fever. He had a high, heart rate, um, normal respiratory rate, normal blood pressure. He was fully alert, had good body movement, but still you could see swollen tonsils now bleeding with white patches and the same bilateral neck tissue swelling. They ended up doing a throat swab, which confirmed the bacteria, Corynebacterium diphtheriae, which is the cause of diphtheria in this patient. Actually, at the local hospital, because of the poor air entry, they basically endotracheally intubated him. And, they did an ECG, showed normal sinus rhythm, no chamber enlargement, no pericardial effusion. They also did a CBC to check for hemoglobin, hematocrit white cell count, and showed that he had low platelet count. These were the abnormalities after, checking his CBC. They also did blood urea nitrogen and creatinine levels. They were mildly elevated. They did liver function tests. Those came out normal, but the urinalysis did come out abnormal. Which leads us to ask, how did this bacteria affect the patient's organs and body? So the bacteria actually can make this really potent toxin, diphtheria toxin, which is the main causes for difficulty of breathing, heart issues, tissue damage. It can even cause complications like paralysis, which can lead to death if not treated early and immediately. The patient actually developed a third-degree heart block with bradycardia and was hypotensive for about a week, where they decided to temporarily put a pacemaker to try and normalize his heart rate. On his 10th day of hospitalization, the patient developed myocardial perforation due to improper pacemaker tip position placement, which penetrated heart muscle tissue, causing pericardial effusion, which basically means just liquid buildup in between the heart and the pericardium, where they had to do an emergency pericardiocentesis to remove the liquid and remove the pacemaker, which led the patient back to bradycardia and hypotensive. On a 13th day, the patient developed ventricular tachycardia, which is really, really elevated heart rate, was still hypotensive, and on the 16th day, eventually the patient reached an asystolic cardiac death and ended up dying. Major cause of his death was fulminant myocarditis with continuous arrhythmia. Fulminant myocarditis is characterized by rapid progressive decline in cardiac function. That's what that means. Treatment-wise, on the first day of hospitalization, the patient was given diphtheria antitoxin immediately after doing like an allergy test. Antibiotics such as penicillin, cefotaxime, and the patient was also given milrinone for blood pressure support and can help assist in heart failure. And methylprednisolone and immunoglobulin were actually given for severe myocarditis. This is where we go back to where that pacemaker was temporarily placed for that third degree heart block. And on the 10th day, they ended up doing that, like what I said before, the catheter drainage. They ended up removing 200 milliliters of bloody pericardial fluid, which is a lot. 13th day, they ended up giving the patient inotropic drugs because of the ventricular tachycardia, and because his condition was actually getting worse, his cardiac function was worsening. They ended up giving him a max dose of milrinone and dobutamine, which happened prior to his heart attack, then had the heart attack, and then died. Prognosis wise, for diphtheria, it can range from good to poor depending on how early one starts and reacts to treatment. Once heart complications arise, that's when kind of the prognosis becomes poor, which is what happened in our particular patient. Um, Diphtheria developed in his lower respiratory tract due to the intubation from the local hospital. The second complication would be involvement of the heart, the myocarditis, the progressive arrhythmias. There was actually a study done in Thailand that revealed a really significant association between death and airway obstruction, and cardiac complications with diphtheria. So that's part of the prognosis. Ended up affecting his electromechanical function. It became abnormal due to the myocardial injury. And then remember that pacemaker that was placed has mixed results after doing research, just because there's lots of reports of the fatality rates back in the day between 56 to 100%. It's a pretty invasive procedure and is very life threatening, especially if it's a child that's undergoing it. And the third complication that happened was that perforation due to the pacemaker tip. Prevention methods, basically just, the importance of vaccination and getting early treatment. They're basically the major components in reducing the morbidity and mortality rate of this disease. And that's pretty much it. These are my references.